Hi, and welcome to the SCD Lifestyle Solution Podcast 25. I'm Jordan Reesner, and I'm here tonight with my friend and compadre, Steve Wright. What's going on, man?
Dude, I'm chilling, man. Drinking some water, and I'm super excited for what's going to happen tonight. I don't even think people know what they're about to learn.
Yes, we have a very special guest tonight. And before I introduce her, I want to tell a little story. She contacted us probably about a month and a half ago, and I got to tell you that my wife is probably the most excited person in the world that she actually contacted us. And the reason for that is when she contacted us, we got on the phone, and her and I talked. We ended up talking like 2 hours about small intestinal bacterial overgrowth, digestive disease, a whole bunch of nerdy stuff about probiotics. And my wife is happy because she doesn't have to listen to me talk about it anymore because I have a new friend that will actually talk to me about it. So I'm pretty excited. We've got a very special guest tonight, Dr. Siebecker from www.siboinfo.com. Welcome, welcome.
Hi, and of course I have to say that my husband is just as happy.
Well, thank you so much for being here. We're pretty excited. We think this is going to be one of our best podcasts. You're definitely going to be one of our favorite guests, I think, so far. So I wanted to just start off by having you tell us your background story because it's really powerful, and I think it will help a lot of people. And just kind of share how you ended up so deep into this small intestinal bacterial overgrowth rabbit hole.
Well, yeah, I had been suffering from what was eventually diagnosed as IBS for most of my life, and I had tried, of course, like so many people, tried just about everything a person can think of to get better. And the symptoms were always brought on, as we all know, who suffer from IBS-like symptoms, by food, by eating. And so, mostly I investigated food allergies and alterations in diet, but I never could figure out how to make it really better. And I was always interested in health, and then I eventually went to, I worked in the nutrition industry for many, many years, and then I eventually went on to naturopathic school to become a physician, and I also got my degree in Chinese medicine at the same time. And while I was there, when I was taking my gastroenterology class, there was a recommended reading list, and being the nutritional nerd that I am, I read all the books on the recommended reading list as well as the required. And my professor, I had a couple professors for gastroenterology, but one of them, his name is Dr. Stephen Sandberg Lewis, and he's an incredible doctor, and he knew about the specific carbohydrate diet and Elaine Gottschall's book, Breaking the Vicious Cycle, and he had put that on the recommended reading list. So I read it, and I just knew it was the answer. It described everything. Of course, it's describing SIBO, described so much of what I was going through, and I was so excited, but, medical school is completely overwhelming, and I think it just got lost in the shuffle. I think part of it was that they were very strict, of course, have a very strict legal and illegal list, and there's some controversy over stevia, but back then there was no controversy, and it was absolutely outlawed. And I truly could not imagine how I could get through school without a tiny bit of sweet taste. And of course, honey is allowed, but at the time I was kind of reacting badly to honey. So I just didn't think I could do it. I didn't drink coffee. I didn't take any kind of anything to help me get through the massive schedule. So I think that was part of it, but I just wound up forgetting about it. I was so overwhelmed with school. And then after graduating, I had a real period of a flare of my symptoms, and a couple years after graduating, and I just decided I had to figure this out, and somehow in that process came back to Breaking the Vicious Cycle, remembered about it. I was actually kind of looking into the paleo literature right before then. Of course, SCD is so similar. So I must have just, I don't know how I remembered it, but I did, thank God. And then when I read her book, it was just the most incredible thing again, even better the second time. And, but, now that I had graduated school, I had time, and I just felt utterly compelled to understand everything about it. And I looked into all her references in the back, and I wanted more of an explanation for everything that she talked about. And I haven't been able to find all the answers to all the questions that I've had, but I've been able to find a lot more than I ever thought I would, because what happened was pretty soon after I rediscovered it, I ran back into my old professor, and we call him SSL for short because his name is so long, Dr. Stephen Sandberg Lewis. So I ran into SSL at a lecture, and he had just written a book on functional gastroenterology and had come across the condition SIBO, Small Intestinal Bacterial Overgrowth. So we were chatting about his book, and I, in particular, wanted to thank him again for putting the book on the list. Of course, I forgot to mention the part about how I went right on the diet and got almost completely better within 24 hours. It was astonishing. So I was totally hooked and totally enthused. So I was thanking him, and then he told me about SIBO, and that plunged me into finding out about SIBO. Pretty soon after, I found out about Dr. Pimentel's book, A New IBS Solution, and that's when I realized that for about 10 or 15 years now, the gastroenterology community, a small subset of them, have just been utterly devoted to researching SIBO, and they have found out so many amazing things. It's just gone so far beyond where Elaine went, and found all these mechanisms out and causes that have helped explain so much for me, and developed over the course of these years excellent treatment strategies. But what they haven't done is integrate what we all know about the diet that well. Of course, that's not really their field anyway, so it makes sense that they wouldn't have. Dr. Pimentel's a fantastic doctor in so many ways, and he did create a diet that's loosely based on it. Well, it's really based on the low residue diet, which is sort of a low fiber diet, but it's really only to be used for prevention after the SIBO is gone, and so many people use SCD as their main treatment, and his diet isn't really appropriate for that. But barring that, the gastroenterology community doesn't really know about the diet. So that's sort of my story in a nutshell. Now what I'm working on is fusing them together. I've been doing that for a couple of years and teaching classes to physicians and trying to spread the word so people who suffer from these conditions can get help from their doctors, or from, if they find out about it, from my website, or just get the word out there.
That's so awesome, and thanks for sharing your story. I mean, it's so great to have somebody who went through the medical perspective, the medical lens, and then because of a personal experience that you had with IBS, you kind of made this your mission, and you've been on this research tear, and you're putting together all this information that's so valuable from the same lens that all of us are looking at things from, trying to figure out what we can do to kind of get through this stuff. And I'd love to dive into this SIBO a little bit deeper. So if you could, can you give me kind of a high-level overview of what we're up against with this stuff?
Yeah, kind of like what it's all about.
Exactly. From the lens of people just like you with IBS and celiac disease and ulcerative colitis and Crohn's and all of the IBDs that are out there.
Well, I guess the first thing to say is that SIBO can exist with so many other conditions, and Dr. Pimentel has put forward the theory that, and his teammate Dr. Lin put forward the theory that SIBO and IBS are essentially one and the same thing. But then, as you mentioned, there's all the other diseases that people have, like celiac and IBD, and SIBO seems to be a part of that too. And that isn't so clear. Of course, even the IBS connection, there's a debate about that. But the other conditions, it's not exactly clear how it relates. Does the SIBO come secondary? Does it come right along with? Is it an underlying cause? We don't know. But what we do know is that most of these diseases and many others have SIBO as a part of them, and that if you treat it, you feel so very much better, and many of your symptoms can be helped. So the way I like to think about it is I like to categorize it as in two ways. There's the gastrointestinal symptoms, which are predominantly the symptoms of IBS, and that's abdominal bloating or distension, and that's gas. So for the most part, that's gas, so that could lead to belching and flatulence. And then there's abdominal pain, and then there's the motility disturbances of either constipation or diarrhea. And so those are and concomitantly there can be acid reflux and nausea and other similar symptoms like that. But those are the main symptoms. But then, additionally, there's the systemic symptoms that can go with it for so many people. And these can be, the most common can be food allergies. And I don't mean the food reactions that give those symptoms I just described. I mean headaches and brain fog and body pain and all sorts of things like that that can go on from systemically. And that happens because the SIBO increases the intestinal permeability, otherwise known as leaky gut. I like to call it leaky small intestine to be specific about what part of the body we're talking about. So then the food components are not fully broken down, either because of the SIBO or because they haven't had the chance yet, and they can just go right through the lining, and then our immune system can react to it. They can bind in all kinds of crazy places all over our body and cause reactions. So I like to think of it that way. And then one more thing I just want to answer about your question, sort of the what we're up against part. I wanted to mention that as a physician, and you guys talk to so many people, you probably see this a lot with all the people you talk to, that I see a real spectrum of how people are going to do with their SIBO. There's people, all the way on the miracle side where, a minimal intervention gets them all the way better, and they stay better. Over to the other side where many treatment strategies have to go on for a long time, and maybe they only marginally get better. And that's just the way life is. Anyone facing any problem, there's always a spectrum of people, and it pretty much has to do with the factors of the individual. What other diseases do they have? How did they come into the world? What was all their predisposing factors? So I hope that answers the question.
Yeah, that was great. And before we kind of dive into, the treatment protocols and different ways that you approach handling SIBO, I really want to stop and, we get a lot of questions from people that want to know, looking at reading Elaine's book and learning about the cycle, the vicious cycle as she refers to it, and how SCD can break that vicious cycle. They always want to know, how do I find out if I have small intestinal bacterial overgrowth? How do I get a test or something that can tell me for certain this is what's going on with me? And I would really like to ask you that question and say, do you actually have ways and testing methods that you do use that you believe are actually reliable, or do you sort of congregate a degree of symptoms together and use that to sort of make more of a diagnosis?
Yeah, it's a great question. And both of those options are available to people, and physicians use both. So you can just go off symptoms along with history. Really, one of the key symptoms is going to be abdominal bloating, but that doesn't even have to be there. It's really the symptoms of IBS that you're looking for, and then maybe one of the systemic symptoms. But even if you don't have a systemic symptom, if you have the symptoms of IBS, it's really worth considering. I myself like testing, and we've been using testing for a couple years now. When we first started with it, I don't think we really knew how to interpret it properly, so we felt that our results were a little bit more unreliable, but over time we've really learned a lot about how to use the testing, and I feel very good about it now. And the testing is the hydrogen breath test. And it is taken as a breath sample, and it measures both hydrogen and methane. Really, it should be called the hydrogen methane breath test, but it's just called the hydrogen breath test. And the way it's performed is most people can do it at home with a kit that you can get from the doctor. You take home and you take breath samples. You just breathe into a little tube every 20 minutes for 3 hours. Now, there are different lab companies that offer testing kits that run for different lengths of time. All the studies, all the research studies go for 3 hours or longer, and so that's what I use. And I have found examples in my practice where if I hadn't gone for 3 hours, if I had gone for 2 hours or for 1 hour, I might have missed some information that I needed to know that the test was positive. So I prefer a 3-hour test. But the drawback to that is that it's a little more expensive because there's more equipment and more time involved for the processing of it. But I think that's the best. I mean, that's what I like to use. Other physicians may have other opinions. But I really like that test. And then there's 2 forms of it. You can use it with a sugar solution that you drink that is either lactulose or glucose. And both are used across the board 50-50 in research studies. But I like to use the lactulose because it will show me if there's SIBO in the lower part of the small intestine. And I find that to be more common, actually, because it's closer to the colon. And a lot of people, we feel that this comes as an overgrowth coming from the colon. Although also some studies show that the overgrowth can be a bacteria down from the mouth as well. But I do think it's more distal. So the lactulose can tell that better. The glucose, the problem with that is that it's absorbed so quickly, so high up in the small intestine, it can only really reflect the first 2 feet. So if I'm going to give someone a test, one test, I will give them a lactulose test. And, you know, something you might be thinking is, you know, well, doesn't that feed the carbohydrate, feed the bacteria and cause problems and cause the very problem? Yeah, it's causing the very problem that, that the SCD diet is trying to avoid, but that's how we can test for it. We have to challenge, we have to aggravate. So when we take the lactulose, it can't be broken down by humans. We don't have the enzymes to break it apart, only the bacteria do. So it goes down into the small intestine, and if the bacteria are there, they'll break it apart and eat it. And whenever they eat, they always make gas. And the methane and hydrogen gas, a portion of it, will diffuse across the intestinal lining into our blood, and then that'll diffuse into our lungs, and we'll breathe it out. And that's how we can perform the test. And the small intestine aspect of it is about the time. There's about an average 2-hour transit of food and drink through the small intestine. So when we get into the 3rd hour, that's usually when we see quite a rise having to do with the colon bacteria, which there should be colon bacteria, and we should really see a rise. So that's how we can tell. It has to do with the timing and the substance that's taken. So I hope that wasn't too lengthy of an answer, but that's the test, and I like it.
No, that was perfect, and that's going to help so many people because they're going to be able to take that, listen to it again, maybe take some notes, and go and have an educated discussion with their physician, and that is powerful. So thank you for that. That's one of the best explanations I've actually heard. So that was great. And
actually, there's one tiny other thing I want to add to it, which is just that what I feel the importance of testing is that the first test, of course, is very important to figure out if you have it. But really, it's the follow-up testing that can oftentimes be even more important, because for a physician, I don't like to guess, and I don't want to be going moving around in the dark, just taking stabs at things. I want to know what's going on and track it. And so after you do your treatment, when you take a retest, you can definitively see how successful you've been and what you're doing. And then you can move forward in a much better way. So that's also something I would recommend to the listeners to plan for.
awesome. Continue to blow my mind every time we speak. So
Can I interject real quick?
yeah.
Well, I just wanted to ask, when you're treating somebody, how often should we get a follow-up?
Well, I mean, it depends on the type of treatment you're choosing. But
Okay.
We haven't fully discussed yet. But if you're using one of the quick killing methods, as I like to call them, such as antibiotics or herbal antibiotics or elemental diet, then you want to come in for your breath test or have it available at your home to do really within a week of finishing that treatment. And that's because the intestinal bacteria can recolonize within 2 weeks. of antibiotics or, some kind of strong killing method. So to get a sense of what you've just accomplished, you should do it within 2 weeks and probably by the end of the first week. Dr. Pimentel's recommendation is within 5 days, but there's probably a little leeway there. So just in terms of that aspect, that's when you would want to follow up.
That's a great segue to my next question. So, okay, so I've done a test and it shows that there is some small intestinal bacterial overgrowth present, or my symptoms are telling me that I have that. I've talked over with my doctor. We decided that everything's pointing to the fact that I have it. What do I do now? So what advice would you give someone who's just found out that they have SIBO, and what are the treatment options that are out there and that you've seen actually work?
Well, I present it that aside from doing nothing, the options that I see are 4. The first would be antibiotics, and the main one that's used is rifaximin because it doesn't absorb, virtually doesn't absorb at all into our system, into our body. It stays in the intestine. So it's very effective and safe. And other antibiotics are oftentimes combined with it, depending on the symptom picture or the gas presentation. And by the way, I didn't mention that with testing. It's another reason why I often need to see a test. It's because the prescription I'm going to give depends on what gases are made. So the first is antibiotics. Then second would be herbal antibiotics. And many people do want to choose this option. They feel very skittish about antibiotics. Oftentimes antibiotics is what's caused them to have this problem in the first place. Totally understandable. So with herbal antibiotics, there hasn't been the fabulous research studies that there have been with antibiotics, because of course who's going to fund them? It's not so easily accomplished. But there has been one study which really, by a wonderful naturopath named Dr. Logan, on enteric-coated peppermint oil, but it really didn't come up to the performance level that we need. So I think it would be fine to go ahead and try the standard herbal antibiotics that have been around that everyone knows to use. And the 2 main that I think of are the berberine-containing herbs, which are things like golden seal or Oregon grape or coptis, things like that, or garlic in high potency in pills. One caveat about that is that there are many people who can't tolerate garlic very well. That usually has to do with a liver detoxification permutation, sort of. Those people usually know who they are, but just in case they don't, the way you'd know is if you start one of these high-dose garlic antibiotics, herbal antibiotics, you would feel worse and worse and worse, really, really bad and very nauseous, and you'd want to stop. Yeah, it's beyond a normal die-off. So there's herbal antibiotics, and the dosing isn't clear on that. The length isn't clear because not enough research has been done on that. But there's stabs that can be taken at it. I think probably like a 2-week, similar to an antibiotic regular course, could do the job, maybe longer. So there's that. Then the third option would be elemental diet. And this is a confusing terminology and category for people. So I'll just describe what it is. It's taking the nutrients you would have in food and having them pre-digested in a lab and broken down to the most digested parts of all the food. So, and then it's a powder. So for protein, it would be amino acids. And for carbohydrates, it really should be glucose, although oftentimes the formulas contain maltodextrin. And for fat, it should be free fatty acids, but oftentimes the formulas just use oil. And then all the vitamins and minerals that we need are included as well. So this is a powder that is mixed with water, and it's used in hospitals a lot, and it's also available over the counter. And so that's how people would obtain it. They can just buy it off the internet or over the counter. And where people, I think, get confused is they think about protein shakes or, and the proteins used in protein shakes are not fully pre-digested down to amino acids. Or they think about cleansing or detoxifying formulas, especially in the naturopathic supplement world. Those are very commonly used. Some brand names are things like UltraClear and MetaClear, things like that, ClearVite, but that's also not an elemental formula. So I just wanted to clarify that because a lot of times people get confused. So what the idea with an elemental formula is that with the antibiotics and the herbal antibiotics, you're doing something to kill the bacteria, inactivating their DNA or their RNA or something like that, their ability to replicate. But with the elemental diet, what you're doing is just starving them. You're just not allowing them any sustenance because these nutrients they're totally pre-digested, which means that your body doesn't have to do any work and it could just be absorbed right into the lining high up in the small intestine. And hopefully, if you don't have bacterial overgrowth all the way as high up as your stomach, then you should be able to just absorb it without them eating it. And it's very, very effective. So that's the third option, and that's also done for 2 weeks. And then the last option that I think is really available for treatment is diet alone. Many people do choose diet alone. They don't. Those first three methods that I mentioned are the quick killing because they're going to happen in about 2 weeks. But diet takes longer, but is very effective. And so many of us on the specific carbohydrate diet, that's what we've chosen. And all of those options are valid. Any mixing of them is valid and can be determined between the patient and the doctor.
Wow, that was awesome. That was probably one of the best explanations I've ever heard in terms of treatment options. And I really want to dive in on, you brought up die-off, and I've got to ask your opinion on die-off because it seems to be somewhat of a mysterious thing. And we get a lot of emails about it, asking what it's like. Is this die-off? Is this not die-off? How can I tell? So could you shed some light on your clinical experience with what die-off is like and kind of how long it lasts and how to tell if that's what it really is?
Yeah, I find it mysterious also. It's not the easiest thing to understand, and I don't think there's been a lot of work, by researchers focusing on it. So I'll take the best stab at it that I can, but I think what's going on, I do think it exists. You see it in so many people experience it. I think what's going on is as the bacteria die, they release components, maybe gas, maybe endotoxin, maybe acids, things that were in their body, in their little bacterial bodies, get released, increasing our symptoms. And I do see people experience this. Definitely, whenever anyone goes on, really commits and goes on the specific carbohydrate diet, most people do seem to have this reaction. I think if they were on a very similar diet, maybe that would be avoided, but particularly if they were eating a lot of carbohydrates and made a more drastic change, I think the diet will be more drastic. It seems to happen, it's different for different people, but I think around the 6th day is often very common. It could be as soon as the 2nd day, and it could last through maybe the 6th day. I would say a week is about the time frame. I mean, if it starts on the 5th day, it may go longer. But I think most people experience it for at most 3 days, I think. And it happens with the other things as well, with antibiotics, with herbal antibiotics, and with elemental diet. In all scenarios, the bacteria are dying. So I've seen it with all of them. Interestingly, it seems to be a little less so in what I see in my clinical practice with rifaximin, with the antibiotic. I'm not exactly sure why. I've certainly seen plenty of people have it, but it's not quite, the worst one seems to be the elemental diet. That one really is tough for people. Although I've seen a lot of people have tough diet reactions going on SCD as well. Now, something else I wanted to mention about it is it could also be what we attribute to diet. Well, before I go there, what are the symptoms? It could be an aggravation of any of the symptoms you normally have, so just a worsening of anything you normally experience. And it could also be things like flu-like symptoms, fatigue, body aches, headaches. These are very common, or feeling kind of like you have a cold, something like that. Those are the kind of the classic die-off symptoms. But something else that could really be going on too, particularly when people go on the diet, is it could be confounded by low blood sugar or blood sugar reactions. because when someone's going on a low-carbohydrate diet, there's a whole adaptation process, maybe to move more into ketosis, burning fat for fuel, not so much carbohydrate, or just because people don't know how to do it quite right and they're not feeding themselves enough. So it could be both, but I think that can aggravate and lump into what we call die-off sometimes.
That's what we've seen. It seems to be like about a week, especially because in our approach to SCD, people start out on the intro diet, which is kind of a model of the elemental approach. So it's kind of a good hybrid, and it seems like if it's going on more than 5 days, it might be something maybe food related, and otherwise it's probably just die off. And you get through it, and it's pretty awesome once you're out the other side. And
And it's awful when you're in it.
yeah, yeah, no doubt. So let me ask you this. Is SCD a small intestinal bacterial overgrowth cure? Or I guess what I'm really thinking is, are antibiotics necessary in your experience? Or do you think that it might be better to have both?
Well, just looking at the first part of the question for a moment, it kind of depends on what we mean by cure. You know, and I think there might be two definitions out there. There could be the definition of cure as not having any more symptoms and having tests come back normal. And then there could be the definition of being able to return to a full standard American carbohydrate diet. So, you know, there could be two definitions, and it depends on which one a person's using. But in terms of whether antibiotics are necessary, I find often that they are. You know, I happen to see, because I'm training physicians on how to do this in my area, on how to treat small intestinal bacterial overgrowth, I wind up with a lot of referral cases that are the most challenging cases. So I do find that I do need to use antibiotics or herbal antibiotics often. Then I certainly know of cases where they're not needed, and it refers back to the spectrum I was mentioning. There's absolutely a spectrum of what people are going to need. And I think, you know, what a person can do is they can try whichever intervention they have a gut feeling, as we all like to say in our realm here, a gut feeling of which one is right for them, or what they decide with their doctor if they're working with a doctor. But certainly diet would be the least invasive and most natural, and everyone can try that at home. And like Elaine said, you know, if you're not feeling better or some kind of difference within a month, the diet alone is not going to be enough, or maybe something else is really the culprit of what's going on. But I will have to say I really do see cases where more is needed. And that was kind of surprising to me, because I came to this through the dietary world and that path. Particularly the cases with constipation. And we haven't directly talked about this, but one of the things that Dr. Pimentel found out, which is an amazing help, is that constipation is actually caused by methane gas. There are some people that have constipation who don't make methane gas, and they make hydrogen gas. So that can exist. But the constipated patients, really chronic, unremitting constipated SIBO patients, they are the more challenging patients to treat. That requires usually many interventions. Diet always gives relief, some relief to everybody, some relief that I see for the most part. But you know, I see very challenging cases with extremely high levels of gas, which means extremely high levels of bacteria. And oftentimes the quick killers, one round is not enough, and I have to use all three options in succession, varying what I'm doing to get that bacterial load down. So I do see it. I do see that sometimes it's needed. But wrapping up and going back to what I was saying before, it's absolutely worth a try first with diet.
Well, thank you. I think you made a good case for SCD there, but I do agree that there probably is some cases where you're going to need a little more. And one of the things I really wanted to get more specific on is when you're using SCD, whether you're using it as the primary way or whether you're using multi-interventions like you talked about, so maybe you're using antibiotics and SCD together. Either way, what are some of the pitfalls of SCD, if any, some things that you can do that may be SCD legal, but they're going to work against you in overcoming SIBO?
Well, it's probably going to be a lot of the same stuff that you mentioned on your site, which I know we have a lot of similarities in our thinking. Really, I think it can be the carbohydrates because that's the food for the bacteria. And certainly all kinds of carbohydrates are allowed on the specific carbohydrate diet. So, if you look at Dr. Haas's original work, he didn't allow nuts. And I know you all are, I think it's very helpful that you are cautioning people to be careful with the nuts, and I agree with that. And, he didn't have nuts on there on his original specific carbohydrate diet, and he didn't have beans either. And in fact, he didn't have yogurt either. He didn't have probiotics. And his diet was a little bit different. But then again, he stressed fruit. So, there's all these variations of the specific carbohydrate diet, also as we see with GAPS. But so anyway, I think the pitfalls can be having too much carbohydrate. Certainly having too much honey can be aggravating to people. The idea with the honey is that if the bacteria is not overgrown very high up, we should be able to absorb the glucose and the fructose in the honey before it reaches the bacteria. But that might not be the case. Or if there's, I've been working a lot on understanding how to relate the FODMAP information and in general fructose malabsorption information with SIBO, and I've definitely found a few studies that show SIBO actually causes fructose malabsorption. So there might be people that can't tolerate the honey because of the fructose, and it will feed the bacteria. And vegetables can be problematic. It seems crazy to think, but Dr. Haas was very, very slow on the introduction of vegetables and very careful. And he thought of that as an aggravating food that should be moved ahead with very slowly. Same would be true for fruit. So any of the carbohydrates need to be handled with care. I think another pitfall that we can all fall into is, and I know you guys speak to this so well, when we're trying a new food, and it's usually a carbohydrate, and we'll eat it, and then we'll go 20 minutes later like, oh, I feel fine. I guess I can just eat more. Not be systematic about it because, we want it so bad or it tastes so good. Or maybe we'll go, well, I had it earlier in the day and I'm fine now, so why don't I have a quadruple serving of it? So I think that's another pitfall. And I do tend to see that us SCD folks can really overeat the things that, are SCD legal but that are carbs. So I think we have to be careful with that. I think those are probably some of the main pitfalls that I can think of in terms of working against the SIBO.
That was an awesome list. I think I just wrote a whole page of notes, so hopefully everyone else listening is going to get a lot out of that. That was really valuable. And I have to follow that question up with, how long would someone with SIBO expect to be working on this solution? And I know it's going to be different, in different cases, like you talked about the spectrum, but a lot of people want to know, is this really a lifelong sentence?
Yeah, I wish I could give a simple answer, but I can't. It really is a spectrum. I mean, if we look at what Dr. Haas was working with, he was working with children, and it wasn't a lifelong sentence. That's what's so hopeful and inspiring about his work. His rule of thumb was to stay on the diet 1 year after the disappearance of symptoms, and then after that point, the children could begin eating a full spectrum of a diet again. I've read his book closely, and the shortest case example I could find in his book was a child that got symptom-free in 3 months. Was a 9-year-old, and so that would mean that person was on the diet for 1 year and 3 months. But then you have the other spectrum where you have Judy Gottschall, Elaine's daughter, who she felt better in 2 weeks. But it took 2 years for her to become symptom-free. It's a pretty good thing to know. And she was, she started seeing him at about, I can't remember exactly how old she was, but I know she got diagnosed with ulcerative colitis at 4 years old. But so she was a child, and it took her, 2 years versus this other case that was 3 months to become symptom-free. And then, we all know probably the famous story that Dr. Haas passed away 2 years into her treatment at the age of 94. And so they didn't know how long she should stay on the diet, so she stayed on it for 7 years. But then around age 12 or 13, she went on to a full diet. And her story, as we read about, is that she can eat anything except her whole life, except rice. Rice brings her symptoms back. So it's a spectrum. Now that's the children. And what I would hold to what Dr. Haas says, which is that children have the best chance of having a complete cure the way Dr. Haas described it, which is that they can return to a full diet of any carbohydrate food being included. So, and then you have people saying that adults may need to stay on the diet for their life to be symptom-free. But then you look at some of the writings of Dr. Campbell McBride from the GAPS diet, and she's having even adults, I believe, move into fluid milk maybe at around 1.5 to 2.5 years, and expanding the diet out after that, after maybe 3 years. So there's a spectrum. Now, I've seen patients who, at 3 months, were able to start eating, one patient in particular I'm thinking of, gluten-free grains with no problem at all. She tried some of the gluten grains. That didn't work well for her. And so she's doing great. And that was at 3 months. And with her, we used a specific carbohydrate diet and antibiotics. And then, then I was just telling you about the new SIBO website called SIBO-IBS.org. And the author of that site, I don't know how long it took him, but in his story, he's now back to eating pastries occasionally after a terrible bout with SIBO. So there's a real spectrum. I think what's good to know is that I think most people hope that they'll be, the miracle who they can just, maybe take antibiotics or get on the diet for a short amount of time, and then everything's better, and they can go back to eating grains. I think many people hope for that, and that's fine, and that might happen. And so it might not need to be a lifelong sentence. Certainly, there are many cases of that. And then there's going to be people on the other end of the spectrum who they'll need to stay on even a very strict version of the specific carbohydrate diet, and maybe even have other interventions. But they may need to stay on that for their life to remain symptom-free. But the thing that's amazing about that is that it's possible for even those people to attain a symptom-free state. Maybe not in all cases, but because some cases are extremely confounding and challenging with concomitant diseases. For example, what if somebody has had their ileocecal valve surgically removed, so there's nothing to prevent the bacteria of the colon to just completely come into the small intestine, and if they additionally have their migrating motor complex, which is the cleansing way of the small intestine that clears bacteria away, if that is then inhibited from some reason, suppose they have diabetic neuropathy also. What if they're on opioid drugs for some other reason, then they really must be on that pain-killing drug, and it stops all motion in the small intestine, well, in the whole gastrointestinal tract. These are things, well then, yeah, that kind of a person, it's a lifelong sentence. But like I want to say, for people on that end of the spectrum, I don't think that it's going to be unwelcome news to them that they could achieve symptomatic success with a diet.
Wow, thank you. That was great. It's so refreshing to hear someone speak not only from a perspective of the deep research that you've done, but also the clinical experience, to be able to tie the two together and just help us look at things in terms of what we're dealing with every day.
Yeah, I wish it could be so simple. I wish I could just say, yes, everyone can get better in 3 months, but it doesn't go that way.
Yeah, sometimes people just need to hear what they don't really want to hear, right?
Yeah, and maybe some people will be the miracle cases, but I don't know. I don't know how I would know.
All right, well, I'm having to literally restrain myself from diving into 30 different rabbit holes that you've touched on tonight. So I've tried to keep things rolling, and I really would like to ask you one final question before we wrap things up, which is, what should our listeners be doing for the next 30 days, 90 days, 1 year to not only work on overcoming SIBO, but to make sure that they don't have it come back again?
Well, that's the question of prevention, and because everyone probably listening to this knows all about the specific carbohydrate diet, and that's really going to be the key thing for most people is following the specific carbohydrate diet for prevention, because if you're, the food that we put down in our intestines for the bacteria or not is the key factor. But there are other things involved with prevention. I see that oftentimes diet is not enough. And in fact, I think this is where a lot of gastroenterologists run into trouble. They haven't read the suggestions in the work of Dr. Pimentel. They don't know that a prokinetic agent is oftentimes needed to prevent relapse. Recurrence is very common. And the reason it's so common is because some of the underlying causes for SIBO are going to be the inhibition of the preventative factors, of which I just mentioned a little bit before. The main one is the migrating motor complex, which is the fasting movement of the small intestine that sweeps the bacteria away. That's really key. And many people have this not functioning, and that's really why they have the SIBO. And another preventative factor is hydrochloric acid in the stomach, and many people don't make sufficient hydrochloric acid. So I think those are going to be two things in addition to the diet. You all recommend enzymes, and I think that's great too, because that's another preventative factor for bacterial overgrowth, making sure we digest our food completely so we can absorb it. So a listener could think about taking hydrochloric acid supplementation. There are some you can buy pills like that, and then there are some even more sort of natural ways, like you can take Swedish bitters or bitter herbs to stimulate your own production of hydrochloric acid, or a little apple cider vinegar in water. Those are two standard ways, but hydrochloric acid pills are great too. You just have to watch out for a feeling of burning or heaviness afterwards, and that will tell you that you're taking too much or it's not for you. And then the prokinetics are mostly prescriptive agents. There's really only one or two left on our market today, and you'd have to arrange that through a physician, and those are erythromycin and azithromycin. You may recognize those names as antibiotics, but in this case, they're not used at the levels where they really work very well as antibiotics. They're used at very low levels. In fact, you need to go to a compounding pharmacy to get the erythromycin. It's so low. And what they do is they stimulate the migrating motor complex, and this is often necessary. Some natural ways you could do this would be acupuncture. You can go to an acupuncturist and ask them to treat you for gastroparesis, which is also known as stomach paralysis. Some very good studies on that. And another natural agent is actually Acidophilus and bifidus. They've both been shown in the literature to stimulate the migrating motor complex. Of course, bifidus is considered illegal by Elaine, and many people choose to avoid it, and many people are aggravated by it, and then many other people find it helps them. So leave that up to listeners' discretion. Acidophilus could also be used. What I don't know is how potently the natural methods stimulate the migrating motor complex, because it hasn't been studied well enough. So it may not be enough. But if you are going to take a probiotic with the intention to stimulate the migrating motor complex, I would recommend taking it before bed, because that is when the migrating motor complex has its biggest chance to do its work, because it happens when we're fasting, and so that's when we're sleeping. And it's a very strong wave at night. And another thing you can do is try and keep 3 to 5 hours between your meals in the day. This is a suggestion that comes from Dr. Pimentel as well, to allow some time for fasting in the day to allow more chance for there to be a migraine motor complex. So prevention is this is an area we really need to work on. You know, many people can get the bacterial load down if you're not seeing really challenging cases like how often I am, well enough, even with diet alone, certainly well enough, but then it can come back. So this is an area we all need to work on. We all, meaning physicians, figure out the best course of action. But that's what I know so far.
That was pretty amazing. So I just want to make sure that I can kind of sum that up. And so in terms of prevention, long term we're talking about diet and then possibly maybe some betaine HCl, which we've given out videos on, digestive enzymes, which we're always talking about, and then probiotics as well. Is that correct?
That's right.
Excellent. And you know, we always usually recommend people to start with the Lactobacillus acidophilus until they start to feel a little bit better and then branch out and get more of a multi-strain at that point. I know it's kind of a hot topic in SCD, but I just wanted to throw it out there. We could do a whole nother podcast on on that and the research about diversifying probiotic, but I think we'll just stick with that. So that was really one of the best interviews we've probably done at this point, and there was so much good stuff there. I just want to thank you again for your time and bringing your experience and your personal story and all your research to the table. It's so valuable for us, and I just want to, since we're running out of time, I really want to ask you, you know, our readers can find out more information on SIBO and the research you're doing and also the book that you're working on at siboinfo.com. And I'm also really excited, Steve and I are going to be attending your upcoming class on September 17th, the SIBO Clinical Strategies course. Do you want to talk a little bit more about that?
Well, this interview has given a good overview of what we'll go over, but I'm so excited because I've been teaching these full-day continuing education classes to physicians and health practitioners, and now finally this is the first time I'll have it available as a webinar, so people from anywhere in the country can attend if they choose. And also after the class is finished, we'll have the recorded webinar available for purchase, and that can all be from my. You can access that from my website, and there's a full description of the class with an outline for anyone who would like to see it on the hosting site that is offering my class, and that is 7waveswellness.com. But there's a link to that through my site as well.
Excellent, excellent. Steve and I are going to be there, so hopefully you can join us. You'll be actually learning topics alongside other doctors and gastroenterologists from around the country and possibly the world. So if you want to actually be educated on SIBO enough to be able to go in and talk with your doctor about it, that's probably going to be a great place to do that. So I think that about wraps it up. Steve, did you have anything kind of to wrap up this podcast tonight, man?
No, I just really want to say that this has been great, and thank you so much for coming on the show, Dr. Siebecker. Your knowledge is like Jordan has repeated a couple of times. It's invaluable to the community and to the people listening, and to Jordan and I. So we are super excited about the class, and we're really happy that you're able to come on and come onto the podcast tonight. And we hope maybe we can invite you back for many more. I don't know.
I would absolutely love to come back. Like I said, my husband is so thrilled to have someone else to talk to. And I'll come back anytime, and we can talk about every little nitty-gritty thing.
Perfect.
All right, well, we're going to hold you to that, and we're going to look forward to it. But in the meantime, thank you for your time again. This has been Jordan Reisner and Steve Wright with a very special guest, Dr. Siebecker from SIBOinfo.com, and this has been podcast 25.